Hello, and welcome to Riverside's Heart Month lecture series. In honor of Heart Month, Riverside is excited to be presenting a new community lecture on a different cardiovascular topic each Thursday this month. Today, we will be focusing on vascular health, which focuses on the circulatory system outside of the heart muscle itself. We have 4 surgeons with us tonight from Riverside Vascular Specialists. Dr. Mohan, Dr. Babadjanov, Dr. Torres, and Dr. Zichal are joining us to talk about vascular health, risks of peripheral arterial and peripheral vascular disease, the importance of lifestyle management, and new treatment options for vascular and arterial problems. There will be a lot of information covered, but the beauty of video is you can rewind and listen again if you want to rehear any particular part. With all of that in mind, let's get to tonight's presentation. Without further ado, I will turn it over to the first of our surgeons this evening, who I believe is Dr. Mohan. Dr. Mohan?
All right, thank you all so much for being here. It's my pleasure to talk to you all a little bit about vascular disease. To start it all off, I'll be talking a little bit about venous disease. I'm gonna start over.
I think that's a good idea.
Yeah, nothing was clicking.
Okay.
All right. Thank you all so much for being here. My name is Dr. Satish Mohan, and one of the vascular surgeons here at Riverside Regional. And I'm here to talk to you a little bit about venous disease, and we'll continue on to talk a little bit about more arterial issues as well. So as vascular surgeons, we have the pleasure of treating both arterial disease and venous disease. And as you may know, arteries bring blood from the heart down to the feet, and veins take it from the feet back to the heart. And while on the surface, they're all just tubes, the physiology and the mechanics of how blood flows within these tubes is very different. I'd like to start off by talking about venous disease. And this is important because it's a very common thing that we see. We'll focus on the legs today because that's the source of majority of issues. In the legs, there are both deep and superficial veins. The deep veins do the majority of the work in bringing blood back from the legs. They're smaller down in the calf, and then as they go up the leg, they get larger in caliber. Superficial veins are closer to the skin, and they take up any excess fluid in the legs and small capillaries near the skin, and then join with the deep system, either in the groin, in the case of the great saphenous vein, or behind the knee, in the case of the small saphenous vein. There are also smaller connections between the superficial veins and the deep veins all along the leg called perforator veins. All of this is pertinent to us as vascular surgeons because all of these various segments can have problems. Now, how does blood get from the legs to the heart? Now, in the arteries, the heart actually pumps the blood. And so there's a pressure that drives the blood through the arteries to the various organs and tissues. Now, from the tissues and organs, it gets back to the heart through a series of biomechanical steps. So from the legs, the muscles in the calf, mainly the gastrocnemius and soleus muscles, contract when we walk. And this compresses the veins and actually pushes up the blood through the veins. And to prevent the blood from coming back down, there are these one-way valves inside these veins that prevent the blood from flowing back down. You can see these various images here. On the bottom left, you can see that blood is able to flow this direction to the right, but can't flow back because the valves close. And then there's a small GIF here that shows you how these valves open and close. And the top right is a histological image of showing you just how thin these valves are. Now, moving on to what kind of problems we see with veins. This whole talk could span over multiple hours, but I'm going to focus on just the most common things that we see, and we'll do a brief overview. You may have heard of something called DVT, or deep vein thrombosis. This is a scenario where blood forms in the deep veins and prevents blood from flowing up. And so this leads to swelling. We'll talk about that in more detail. The other common thing we see is chronic venous insufficiency, which can lead to things like varicose veins, skin darkening, and even ulcers. We'll start off with DVT. Now, this is simply, in essence, a blood clot that occurs in one of the deep veins of the leg, most typically. And what can happen is that this can be partially occlusive or completely occlusive and causes blood to back up in the leg and essentially lead to swelling of the leg. This can be very painful, and in more severe situations, pieces of this clot can break off and travel to the lungs, potentially causing very life-threatening issues with what we call a pulmonary embolism, or PE. The other thing that can happen is that blood can completely stop up all the blood. Blood clots can stop up all the blood flow, and this leads to severe swelling in the leg to a point where the small tissues and skin and muscle and nerves aren't getting the oxygen they need. And this can lead to something called phlegmasia. And this is an urgent problem where we have to relieve that blockage to restore oxygen. In the long run, chronic DVTs can cause these small valves in the veins to function improperly, and we lead to chronic reflux, meaning blood flow in the wrong direction. And this can lead to skin darkening, skin inflammation, scarring, and even ulcers. How do we treat DVTs? The most important piece of this is blood thinners. And this is not necessarily to break down the existing clot, but to prevent any new clot from developing while the body breaks down the clot on its own. So typically, patients are on blood thinners about 3 to 6 months. In certain situations, patients can't get blood thinners because they have some kind of bleeding issue. In these situations, we can consider placement of an IVC filter. This is a specialized device that's placed in the big vein in the belly called the inferior vena cava, and it's like an upside down umbrella. And its purpose is to catch any clot that may break off from a blood clot in the leg so that it doesn't go to the lungs. Of course, with all patients that get DVTs, we recommend compression of the legs with compression stockings and elevating the legs to relieve the swelling in the leg. In very severe situations where the clot burden is very extensive and the DVT extends all the way into the pelvis from the legs, we can consider more invasive treatments, including administering clot busting medications called TPA, or even sucking out some of the clot in the cath lab. So we'll go on to the second piece of this, chronic venous insufficiency. Now, this is all fairly common. You may have heard a lot of family members talk about it, or you yourself may have it. This is essentially failure of these valves and breakdown of the valves, leading to kind of thinning of the veins, which leads to varicose veins, which is small dilated veins that can be very painful. It can cause itching, burning, heaviness. It can even break and cause bleeding, which can be pretty significant. And not to mention, this can be very disfiguring of the leg, and a lot of people have issues with that. So some of these images here shows how varicose veins look compared to normal veins. And this is an artist's rendition of someone that has varicose veins along with spider veins and smaller veins. How do we treat varicose veins? There are both open techniques and minimally invasive techniques. Open surgery can include actually pulling out the entire vein and tying it off so that there's no more blood flow through it. We can also make small little incisions along large varicosities and actually pull them out so that they're no longer there. Minimally invasive techniques include ablation of the vein, which is basically going into the vein with a needle and then exchanging for a catheter. And then we essentially burn the inside of the vein and cause the vein to shut down. Again, the goal being to prevent any blood flow through that vein. We can insert some special surgical glue to shut down the vein. We can also inject some sclerosant material that will cause the vein to chemically scar down as well. And depending on the situation, on the symptoms, and how extensive the disease is, we can use one or a combination of all these treatments to treat the disease. So that was a brief overview. Just to kind of finish it off, some things to think about for vein health. First of all, are you at risk for venous disease? I think you have to look at your own history. Have you ever had any vein issues? Have you ever had a blood clot? Or do you have varicose veins now? And you also need to consider your family history. Have you had your parents or your siblings or aunts or grandmothers, anyone with varicose veins? This does tend to pass along in families. And so oftentimes we see it in female family members, and they tend to pass along to their female offspring. How can we prevent venous disease? For blood clots, avoid long periods of standing or sitting without movement, especially things like long car rides, long plane rides. This can lead to what we call stasis of the blood flow and increase your propensity to develop a blood clot. If you know that you're going to be standing for long periods of time, or your job or day-to-day activities require you to stand for a long period of time, consider wearing compression stockings. This will give you some support to the veins and prevent the blood from just pooling down in your legs. And skincare cannot be missed. It's very important to wash your feet daily, dry them off, and apply some kind of moisturizing lotion so that you don't get any dry skin and breaks in the skin, especially in the setting of chronic venous insufficiency. And lastly, if you do have varicose veins or had a blood clot or any other vein issues you're concerned about, come see us. We're very happy to see you and just chat and see if anything needs to be done, or give you some recommendations about how to just treat everything medically. So please feel free to reach out to us if you have any issues. Next, I'll hand it off to one of my colleagues to talk about one of the arterial issues that we see. Thank you.
Okay, thank you. And now we'll talk about aortic aneurysms. My name is Babadjanov. I'm one of the vascular surgeons at Riverside Vascular Specialist. So what is the aortic aneurysm? The aortic aneurysm is the outpouching of the aortic wall, which is abnormal, and it's related to different medical conditions that we're going to talk about later on. And as you can see, it's abnormal outpouching of the aortic wall. So the types of aortic aneurysms is infrarenal aortic aneurysms, which is this one. It occurs about 80% of people. 80% of aortic aneurysms are infrarenal. And then the other one is thoracic aortic aneurysm, which is up in the chest. And this one contributes to about 10%. And then there's a mixture of those two, which is called thoracoabdominal aortic aneurysm, and that's the rare form, and that contributes to about 5 to 8% of aortic aneurysms. So the incidence of aortic aneurysms are in about 1 to 3% of general population. It's much more common in men than women. And it's a 14th leading cause of death in the United States. What are the risk factors for aortic aneurysm? So there are multiple risk factors of aortic aneurysm, and the most important one is the smoking. And anybody who smoked over 100 cigarettes in their lifetime is a high risk of developing aortic aneurysm. The other risk factor is the family history of aortic aneurysms, ruptured aortic aneurysms, and connective tissue disorders such as Marfan syndrome. And lastly, atherosclerosis and COPD are less important but still common risk factors for developing aortic aneurysms. The signs and symptoms of aortic aneurysms, usually most of the time, aortic aneurysms are asymptomatic and they found incidentally on the CT scans done for unrelated reasons such as abdominal pain, back pain, and so forth. The less commonly they found on the physical exam by other physicians, such as a pulsatile mass in the belly, and the ruptured aortic aneurysms are also like the way it's diagnosed, and this is a very lethal condition where 50% of people usually don't make it to the hospital, and out of those 50% of people who make it to the hospital, 50% still don't survive. So there is a screening for this procedure as well. It's not as common as a screening for, let's say, colorectal cancer or breast cancer, but anybody who is of age of 65 and who smoked over 100 cigarettes in their lifetime are candidates for the screening method as a part of the Medicare welcome package. The diagnosis, so like I said earlier, most commonly it's incidental finding. It's diagnosed as incidental finding on the CT scan done for some other reasons. And then the second modality, the diagnostic modality, is the ultrasound. And that's where we also incidentally find aneurysms. The treatment for that, usually there's indications for treatment, which are mostly related to aortic aneurysm size. So assuming that person doesn't have any symptoms from it, such as abdominal or back pain, the indications are 5.5 centimeters in diameter in males and 5 centimeters in females. Whenever you exceed that diameter, those aneurysms need to be fixed. And the reason why they need to be fixed is because risk of rupture goes up exponentially after those sizes. And whenever the risk of rupture exceeds the risk of surgery, that's when the repair is indicated. And traditionally, repair was done through an open incision and replacing that aneurysmal segment with the synthetic graft. But nowadays, about 90% of infrarenal aortic aneurysms are done in the endovascular repair through the stent like this, and this is the aortic stent that we usually use for those kind of repairs. And it's usually done through 2 sticks in the groin, and then person usually stays in the hospital for a day and goes home the next day. How we decide whether or not somebody needs an open repair or endovascular repair is based on their age, first of all, and some anatomic criteria for the stent. Not everybody can have a stent, and the pluses of the open repair are that it's more durable, it lasts for many years, and endovascular repair may have a good outcomes early on, but later on, after 5, 10, 15 years, there's a lot of other procedures that may need to be done in order to keep that stent open and prevent aneurysm from growing. Thank you, and we will turn it to my partner. We'll talk about peripheral vascular disease.
Hi, my name is Dr. Torres. I'm one of the vascular surgeons here at Riverside. Today I'm going to talk about peripheral arterial disease, which means a disease of the blood vessels that go to your leg and to your arms. We're going to focus more on the legs because that's way more common and it's what gets people in trouble. It's very unfortunate when you have a patient come in and it's too late and they require an amputation when they lose their limbs. And unfortunately in this area we do we have to do a lot of amputations because the patients come really late. So it's important to get this disease early. So there's a spectrum of the disease. It can come with completely asymptomatic, meaning you don't have any symptoms. And then you can develop pain only when you walk. And then you can develop limb-threatening symptoms where you get a wound or you get pain all the time. You get gangrene, and that can result in limb loss. So there are usually three things that we have. Most patients are completely asymptomatic, meaning they don't have any symptoms. So that's a good thing. Then the rest of the patients either have only pain with walking or they have severe disease, and that's the minority of the patients, thankfully. Okay, so first we got claudication, which means pain with walking. It typically involves the muscle groups, so it's either the calf or the thighs, sometimes the buttocks, depending where the disease is at. Most of the patients that have peripheral vascular disease, about 20 to 30% of these patients come with these presentations. Okay, and the good thing is that we get them on time, we can help and increase the amount of distance that the patients walk. Once you have peripheral arterial disease, this is associated with having heart problems and even disease of the carotid arteries. So once you have symptomatic disease of the legs, it means that you probably have the same thing that happens in the leg. It's also happening in the heart or in the carotid arteries that go to your brain. So it's important that we get this early so we can help the entire system. It typically arises at the same distance. Let's say every 4 or 5 blocks, I have pain in my calf and my legs, and then it stops when I rest. And it's not associated with joint pain. So pain in the knee, pain in the hip or the ankle is completely different. And it has very peculiar only in the muscle, because it's basically like a little heart attack of the muscle. You have a blockage in the artery, and then the blood flow doesn't get to the muscle when you walk. So basically every time you walk, you have decreased blood flow. That's why it hurts. Then you rest and it gets better. It's not associated with shooting pain that goes in the back. That could be mostly related to a nerve issue. So it's very important to differentiate no joint pain, no shooting pain like the nerves. It's very specific to muscles because it's low blood flow to the muscles. Then we have limb-threatening ischemia, where the disease is so advanced that you either develop a wound, you can develop gangrene, or you can develop rest pain, which means you have pain all the time, and it's very specific pain in the toes and pain in the foot. And these patients have significant risk overall. Once you have arterial disease that is this bad, not only do you have risk of losing your leg, about 20%, but you also have risk of having a heart attack, having a stroke. So it's a marker for patients that have global disease of their arteries everywhere in the body. So it's important to get this early. You want to try to get it before you develop a wound, because that increases the risk of losing a toe or a limb. So the earlier we get it, the better it is. This is associated with smoking. Anybody that smokes more than 100 cigarettes, diabetes, high blood pressure, unfortunately age, which we can't control, and then high cholesterol and hyperlipidemia. All those things are associated with this. There's also some family history, but the most important thing are the smoking. About 10 million Americans have this. And again, this ranges from like severe to very mild. And then as you age, as you can see, it's higher risk. Unfortunately, we can't control age. It's going to happen. But if we can control the other risks, including smoking, high blood pressure, and diabetes, then we can improve the outcomes in the long term. So what happens is, when you smoke or you have high blood pressure or diabetes, you have a little injury of the artery, and this causes inflammation. And that inflammation, what happens is plaque accumulates in that area, and then that progresses to the plaque gets worse and worse and worse and worse until one day it just clots off, shuts down completely, or severely enough that it causes problem like pain or wounds, etc. But it always starts with an injury to the artery, and that happens when you smoke and the nicotine. When your blood pressure is too high, it's a little tear in the artery that then progresses to have plaque, and then the plaque is what causes the problem. Again, like I said, the most important risk is the smoking. After that, the diabetes is very important. So diabetes that's uncontrolled, doesn't matter if it's type 1 or type 2, any diabetes that's not controlled, it's very important to control it and keep your hemoglobin A1C below 7. The other risks are high blood pressure, age, problems with the triglycerides, cholesterol, all those things, and then kidney dysfunction. When the kidneys don't work, your arteries become hard, and they have issues like peripheral arterial disease. It's very easy to screen patients. This is a very simple procedure that doesn't require any contrast. It's just a blood pressure cuff, and we look at the pulse, and then we make this calculation, and they give us a number, and this takes about 20 minutes, and we can screen everybody that has risk factors very quickly. The normal is about 0.9 to 1, and then most patients only have mild disease, and then you can have severe disease. But the most important thing is symptoms. Here we don't treat numbers. You know, this number could be this decrease, but it's all about the patient. Does the patient have symptoms? That their legs hurt? Do you have a wound? That's more important than the actual number. But screening patients, then you can be aware in the future if something goes wrong that that patient has peripheral arterial disease and it needs to be addressed. But this is how we screen patients. So what happens is you get an injury in the artery, and then that develops a plaque. It's very different what patients that smoke have to patients that have diabetes. Patients that smoke tend to have disease in the abdomen, and then patients that have diabetes tend to have disease below the knee. If you have somebody that has both smoking and diabetes, this is like the worst combination. You can have multiple levels of disease, and those patients usually do poorly. But if smokers tend to have very specific disease, and diabetic patients tend to have another type of disease. So we just got to differentiate. And then, like I said, most patients are asymptomatic, meaning they don't have any symptoms at all. And those people usually do great. We just need to monitor and control the risk factors, like we said earlier. In general, women tend to have worse outcomes because their arteries tend to be smaller and they have more issues when you fix them. So it's very important to take this in patients and have it found when it's early in the disease. And like we said, it's associated with just global issues with your arteries. The patients that have pain when they walk, those patients tend to do well if it gets controlled early. It's very important that the first thing that we usually do with patients that have pain when they walk is to do an exercise program. We don't go straight to surgery. These patients, what we do is we walk them, and once we walk them, that distance can increase, and at some point they might be able to completely walk without any issues. But they need to have an established exercise program, and then good risk factor modification with blood pressure, diabetes, and smoking cessation. Okay, these patients usually don't progress to losing a leg, but it can in about 5 to 10% of the patients. And then the worst is when you have tissue loss or gangrene. Those patients do poorly because not only can they lose their limbs, but those patients can have heart attacks and stroke because the other arteries are also involved. So again, it's important to catch this before you develop a wound or pain at rest. So the most important thing of all this is prevention. And the way we do prevention, as we repeatedly said, is controlling your blood pressure has to be less than 140 over 90, controlling your diabetes, which is less than 7, not smoking, the smoking cessation, controlling your cholesterol and your diet, a healthy diet with vegetables, less red meat. All these things are very important. And then walking. The more you walk, the better it is for your blood vessels because it increases the time. And that's basically it. We start with medication. It's statin, aspirin, and then if patients have issues and continue to have progression of disease, we can do procedures where are minimally invasive, and those patients do great. And it's an outpatient procedure where we just go in the artery and use a balloon or a stent and a roto-rooter and clean up the artery. And those patients do great. If that doesn't work, then you talk about doing bypasses or doing other more complex procedure. But most patients usually do great with either exercise, medication, and sometimes you have to do any interventions. Thank you.
Thank you, Dr. Torres, for handing it over to me. My name is Dr. Ernest Zichal. I'm a vascular surgeon at Riverside Regional Health System, and I'm going to be talking about carotid artery stenosis. So carotid artery stenosis, we are mostly talking about what some of its causes it can relate to, and transient ischemic attack or stroke is one of the biggest causes from carotid artery stenosis that we're most concerned about. A transient ischemic attack, or some people call these mini strokes, are having stroke-like symptoms that last less than 24 hours and completely resolve. A stroke is an acute development of a focal neurological deficit, which attributes to disruption of blood flow to a particular region of the brain, causing its symptoms at that time. Some of those symptoms are problems with speech, problems with vision, and having weakness either on one side of your face or even your arms or legs. Overall, stroke is the second leading cause of death worldwide. The majority of strokes are caused by what we call ischemic strokes. There are also a hemorrhagic type of stroke, which is having bleeding in the brain, which is another type of stroke not related to carotid artery stenosis. Of the ischemic strokes, 15 to 20% of these are actually related to the carotid artery disease, which is why I'm here to talk about that. As I was saying earlier, there are two types of stroke. There's the ischemic stroke, which means you get a clot or a thrombus that either travels to the brain or actually starts in the brain and causes decreased blood flow to portions of the brain, which means those cells in your brain die, and then that's what causes your symptoms of the stroke. A hemorrhagic stroke is something that is, for some reason, you've started bleeding inside your brain. So you're getting blood loss from not having enough blood supply distal to that area. But the other problem is there's bleeding causes a big collection of blood that also then decreases blood flow further because of the buildup of pressure around that area. More specifically, because this is what I treat as the ischemic strokes or related to the carotid artery, their causes of this are from large vessel atheroma or plaque. This is the most common. It usually occurs at the carotid bifurcation, which is in your neck. And the plaque builds up. Either a piece of plaque breaks off from the common carotid artery and goes into the brain and causes a blockage, or sometimes that blockage gets so severe that the blood flow actually ends up clotting off altogether, and you have no blood flow through that carotid artery. You can get a small vessel atheroembolism. It just means it's the smaller blood vessel. Typically, it's going to be from hypertension or diabetes, and those occur inside the brain. And and those may or may not cause symptoms, and you might not even know about that. A low flow state also comes from the overall decreased blood flow in that region, and we call this area, which is the watershed area. This can happen after you've had a stroke. It can continue to evolve because there's decreased blood flow around a larger location. Cardioembolism, probably most of you have heard, you've seen all these commercials talking about atrial fibrillation. That's where your heart is beating irregularly and it causes a clot in your heart. And then unfortunately your heart pumps that clot out and it can go anywhere and cause a blockage either in your arms or your legs or your intestines, but more specifically, it can also go to your brain, which is also a big cause of strokes. Additionally, you can also have some prosthetic heart valves that can cause where clot can develop on those, or you can get some infections on some of the valves inside your heart, which you can also release plaque and cause embolisms. Some stroke statistics: 30% of the stroke survivors do die within the first 2 months, and 60% die within the first 12 years. So if we can prevent strokes, certainly we can hopefully reverse some of these trends and get people to live longer. If you have one ischemic stroke overall within the next 5 years, it increases your risk from 40 to 50% of having another stroke. Some of the risk factors: smoking is probably the biggest one, along with hypertension and hyperlipidemia. Certainly, this is an artery disease problem. So if you have artery disease in your carotid arteries, there's a good chance you also have some artery disease in your coronary arteries, which can lead to myocardial infarction, or you can have some peripheral arterial disease, which can lead to potentially amputations or problems with walking, or diabetes also is another cause, as well as sometimes aneurysmal disease, which means that your arteries are larger than it should be. So there's two types of carotid artery disease. There's asymptomatic and symptomatic. Asymptomatic, overall looking at this, there's about a 5-year risk and obviously the higher the blockage is, the more likely you are to have a stroke. So when the blockage is less than 50%, your overall risk of having a stroke, unfortunately, is about 7.8%. And that's probably more secondary to either those small atheremboli in the brain causing those little tiny infarctions, or potentially that risk is probably from some cardioembolic sources. But the higher that blockage is, so when you get into a blockage range of the internal carotid artery from 75 to 95%, your risk of stroke you can see is significantly increased to about 18%. Symptomatic carotid artery disease so we're looking at the plaque, and you can see from the picture, the normal blood flow in the vessel on the left shows, the blood vessels are wide open. And in that picture on the right, you can see that the plaque buildup is making that space narrower and narrower. What happens, some pieces of that yellow atheroma may break off and go into your brain, and that's what would cause the stroke, because it would block a blood vessel that's significantly smaller. So patients that have been having symptoms, but luckily haven't had either, maybe not showed up to the doctor yet, or they actually had a stroke, but they were able to resolve most of their issues. If they didn't get treated and they had this blockage, if they have a degree of stenosis in the 50 to 70% range, that increases your risk of having another stroke in the next 2 years to 22%. And if you go even higher, 70 to 99% blockage, that increases to at least 26%. So certainly if you're having symptoms from your stroke, we want to treat this, because we can greatly reduce your risk of further having strokes from this area. Signs of a stroke. I'm sure you've seen some of the commercials, and sometimes your primary care physicians might talk about this, but this is the mnemonic that kind of goes along with it, which is FAST, which means you want to, if someone notices any facial drooping, I might have arm or leg weakness, or they're having problems with speech. Another thing might also be problems with vision. It's time to call 911, because the sooner you get to the hospital for evaluation, the better outcomes we can have in treating this, and maybe overall reversing the symptoms of a stroke. So some of the workup that you might get, obviously a physical exam. If you were to have a stroke, unfortunately, this would be the point where we might do some of these workups. Additionally, if you're primary care physician or another physician, sometimes might notice on a physical exam we call a carotid bruit, which is like a sound in the neck that signifies that maybe there's a stenosis in your artery. That would be a reason to also get some of this workup. The first picture up here in the upper left is what we call a angiogram. That's where we actively put a catheter into the carotid artery and shoot dye in the artery in order to look at the blood vessel. This is typically the gold standard and is the most accurate. However, this is also the most invasive and does actually lead to the possibility of having a stroke while trying to do this, unfortunately, because you can, while getting the catheter up there, we can knock some pieces of plaque off in the result of that. So we tend not to do that all as a first round diagnosis. We've got certainly better imaging things, which is usually either a CT angiogram or a MRI angiogram, and they can look at these and do some 3D reconstruction so we can get a good view of the blood flow. And you can kind of see in some of those pictures where there might be a narrowing or blockage. Overall, probably the cheapest and most commonly performed is always going to be the carotid duplex, which is the lower left screen, which we use ultrasound waves, which is what they use to look at babies. But we use this to look at the carotid artery and to look at the flow rates. And we base, how the flow in the artery is going in order to determine what level of blockage there is. So if we do notice someone has the stenosis, kind of what are some of the treatments? And this is where we come into play. This is something that we do. So first of all, your non-surgical management, if we notice you have blockage, but it's asymptomatic, we're probably going to just start, with some medical management using some medications. Certainly if you're a smoker, we want you to stop smoking. If your blood pressure's not under control, you want to get that under control. Certainly if you're diabetic, you want to continue to control your blood glucose levels because that can make things worse, along with your cholesterol too. And those are usually your cholesterol medications we might add, even if you might not have an issue with your cholesterol levels. Certainly if we're going to intervene, we typically do put people on some cholesterol medication because that does help reduce that risk of the plaque continuing to build up. But most commonly, what we're going to be using is probably aspirin and a baby aspirin at that. That helps kind of reduce that risk a little bit. Certainly, if we're talking about treatment and other things, we certainly add some other antiplatelets, some medication that works like Plavix. And sometimes we might even become more aggressive and use some anticoagulation medications like Coumadin or some of the newer Xarelto or Eliquis. These are more commonly used in the people that have the atrial fibrillation because you're trying to prevent that clot buildup overall. And when it comes to surgical management, there's really kind of three ways. Overall, there's two ways. There's an open carotid endarterectomy, which we'll talk about in a second, and then there's carotid artery stenting. There's actually two ways of doing carotid artery stenting. The way that's been around the most and the longest is the transfemoral carotid artery stent, which is where I put a catheter in your groin and go up and place a stent in the carotid artery. And there's a newer type, which is called a TCAR or a trans common carotid artery revascularization, where we actually do it's a mini hybrid procedure where we do a little bit of open, where we do a cut down in the artery and then place a stent that way. And I'll talk about those in just a second. So a carotid endarterectomy is removal of the plaque from within the blood vessel by surgical means, where we actually cut the artery open, kind of pull out the plaque, and then maybe sometimes put a little patch on the arteries that you can see. Like if you had a little hole in your jeans, put a little patch. You can see we make an incision in your neck, kind of along that length where that carotid artery is running. There's some important nerves and some other structures that we got to avoid. We kind of clamp the artery once we get everything open, and then we remove the plaque. and sew everything back shut. The transfemoral carotid artery stenting is where we put a catheter in your groin, and you can see we kind of traverse up through the main tubes in order to get into the carotid artery, and then we certainly place a stent that way. And then this newer way, which is the transcarotid artery vascularization, as you can see, I make a tiny incision. It's still in your neck, but it's lower down towards really your collarbone or your clavicle. We also do access your vein, not your artery, in your groin as well. And then we go ahead and then place catheters, wires, and then a stent through that. We certainly have done all three of these types of procedures, and we, kind of tailor what's the best approach and probably the safest approach for the patient based on kind of the data when you come to us and trying to figure out which way we're going to treat this. And certainly every procedure has its own risks and benefits of doing it the way it's done. And that's something that we can discuss if you ever do have carotid artery disease and end up in our office. This is more of the transcarotid artery stenosis, where you can see us putting the sheath into the carotid artery and then kind of reverse some blood flow to help prevent you from having strokes while doing the procedure. And that's what the stent looks like when you push it up against the plaque. If you have any other further questions, certainly we are available. And thank you very much.
Thank you very much, Dr. Zichal. And thanks also to Doctors Mohan, Babadjanov, and Torres for sharing all of this information with us this evening. It is easy to overlook the vascular part of cardiovascular health, but maintaining healthy blood flow throughout the body is critical, and keeping those veins and arteries open and healthy can help prevent heart attack and stroke. I hope everyone enjoyed the presentation, and I hope you will join us again next Thursday when our lecture series will focus on women's heart health. Until then, thank you again for watching, and I hope you have a great evening. Good night.